you're going to see today, and what we're going to really talk about in detail, is not so much the end of line, the particular devices, but the infrastructure that has to be considered, and the timeframes and essentially the timelines that need to be put in place when considering technology systems as well as healthcare systems that rely on highly reliable, available networks. So here was my brief bio as described. Really appreciate you taking a look at it. It's hard to believe that I've been out of the military for 22 years. I have a lot of great experience in engineering, but the things that I'm most proud of was actually being an installer, because that really gave me the hands-on and understanding of what needed to be done with not only the systems for communications, but the infrastructure that's required and how to design that infrastructure in a smart and constructible way. Here at Level 1, we try to show everyone our design, build, operate, and maintenance of technology system. We focus a lot on infrastructure, and not again those end-of-line devices, but we have those design experiences for all of the systems that we had described previously. I'll show a slide with that as well. A little bit about our Level 1 vision. This is really kind of just a holder slide. Hold on a second, I apologize. I went to the wrong presentation. That was an older presentation, so I apologize. Give me 2 seconds. Okay, back on board. Okay, next is to talk a little bit about Level 1. We are in MBE and DBE. We are in the communications realm of technology. You'll see pretty quickly all the systems, and this is not an exhaustive list, but all of what we do, either from the engineering and consulting. I am a PE, so I am stamping drawings for these systems, going through permit process, as well as the specifications are derived out of our office. We have a team of engineers that we utilize, as well as designers, in order to put these things into place and work well with sometimes direct to owner or underneath an architect in order to bring those systems in. AV telecom security, as well as others, nurse call, and some infant abduction systems that are specific to hospital is part of our repertoire. We also have an installation arm where we're actually doing, on some private projects, doing the installation of the structured cabling, as well as some of the systems and integrations that are required in order to bring those systems up. Technical services, desktop maintenance support. We're trying to be able to not only engineer, install it, but also maintain and operate the systems within either any one of our verticals: healthcare, aviation, intelligent transportation, as well as multitudes of scientific and research. We are specifically looking at how do we make the infrastructure not only our own from a technology and maintenance, from a technology and engineering and smart systems and those kind of systems. How do we make those better? But how do we make the other systems that are reliant on that technology itself? So our markets are vast. One of the things that we're getting into is smart city developments, and it's the integration of all of those systems into something that's called a layer 8 or a data lake, to be able to take the metadata from all of those individual systems and be able to provide that as a solution for where AI or machine learning or others would be able to utilize that to create outcomes from a system that doesn't normally integrate from here to create an input here based on truly just the data migration and the capture of that data, and then ultimately the use and use cases there. I have a lot of experience in healthcare, Kishwaukee Hospital, Jesse Brown. I worked in San Francisco on quite a few HSIR, the research arm of University of San Francisco hospitals. What I found is that the infrastructure that's there quite often on the technology side is not really maintained and not really the high caliber that you would expect out of a large healthcare facility. Now, what does that mean? I'm not trying to put them down, but it's just eventually those things don't become part of the maintenance and operations that you're necessarily seeing on a day-to-day basis. They're maintaining the heater, the air conditioner, the chillers, the electrical systems, distribution of air. Now we have the requirements for the distribution of air to be positively or negatively pressurized depending upon the ward or the specific area you're in. I'll talk through a little bit about what are the tenets of good design, but I want to kind of call out some of the things that have been changing over the years. We see that the medical operations have changed drastically in the last decade. They've changed from the standpoint of going from paper and pen, going from manual systems and dissemination of information to ultimately network-based communication, ordering of services and MRIs and the like, as well as what we've seen over the last 2 years due to COVID is the telemedicine and the telehealth integration of those services with those who are not necessarily near a hospital or are susceptible to infection, and going to a hospital is a higher risk than trying to do it through a telemedicine appointment. I actually had a telemedicine appointment this morning with my doctor, and it was an exemplary experience. We talked through, and they had a list of questions, and I felt like I was in the office working with them. It worked out really well, and I didn't have to travel. I didn't have to park the car and wait in a waiting room. It was immediate. There's a lot of time savings, and if you think about the cost savings involved as well, there is a cost savings. What I've been talking with clinicians about is that there's been change in a lot of medical operations and how they interact with patients, as well as how they interact with the equipment that's out there. What does that mean for technology? Well, there's a component here where if you have a large amount of medical record files, you want those to be available when you have that appointment, so they're not trying to download these things, and those instances can be linked to the calendar of where those appointments are, so that your medical records could possibly be in a on-site or in a hybrid system versus being in a cloud where it can be gathered by multiple doctors at a different location. What does this mean for technology? Well, what we have to think about is what makes a highly reliable system. Those I'll start touching on, but really the highly reliable systems that we talk about are the network components that provide that communication early in the process. The FGI 2022 is starting to change some of the processes and increase the amount of requirements for reliability in a hospital. Over a specific size, let's say over 50,000 square feet, you have to have 2 entrances into the building and 2 equipment rooms that sit within the building itself, so that you can have multiple internet service provision or providers into the building, and that can help increase the availability and reliability. That being said, it doesn't solve every issue, but you have to put it all as part of a system. FGI also is going to take nurse call systems in 2022 guidelines and make more optional. Reason being is that the small, more rural hospitals are getting hit with a system, a nurse call system, that doesn't necessarily meet the direct needs of the day-to-day operations. Sometimes hitting the blue button and calling a code is not necessarily the best way to alert or have those who are in the area be able to provide that. However, that's one of the more mandatory buttons. Something like a nurse or a clinician call to the desk is more over things like radios in certain instances, or mobile devices where they're hitting buttons and calling for additional help. Not necessarily over traditional pull cord nurse call systems or push button, those kind of things. The telemetry and those kind of things start to become more of a technology and less of medical device because of the way that they communicate. Building into a hospital, you have to start thinking about the network availability and resilience to either a physical infrastructure event, like maybe a cut line because somebody was digging out at the property line and they cut up the fiber optics that was coming into the building, or necessarily something like a cyber attack. All of those things have to be start to be considered as part of this, ultimately as part of what infrastructure needs to go in place. That resiliency, what we talked about, multiple service providers coming into a facility from different angles, what that will allow you to be able to do is try and mitigate what an event out at a property line, or even down the road where something that you cannot control the specific infrastructure of may be severed and you no longer have communication. You have to have something that's available and resilient to those types of events. We also think about loss of energy or an energy event where you lose power and you have to go on to emergency generation. What systems and technology need to be on those as well? Not everything needs to, but the majority of these things are considered mission critical in the network side to be able to run other systems. And if you did not have a UPS or some sort of ability to have that gap in a electrical or a down power event, you would have a gap where the systems may go down and they don't automatically come back up to the last state. It may take the requirement of your IT or your support staff to be able to bring those things back up. The infrastructure, being that UPS, that is a hailed requirement as part of anything that is critical to the network, whether or not it's whole building or whether or not it's in rack for specific systems. You want to ensure that you have those things accounted for. We talked a little bit about how those data systems are coming into place for buildings where you can create a more efficient, safer, more reliable building. But there's also a large amount of data, and those networks are being used for electronic medical records, and also the input from clinicians to be able to create second opinions, new data and new outcomes from the data that is entered. Now, I'm not saying that they're replacing doctors, but they may be a checksum or something that creates an additional consideration as part of the interaction that between the patient, the doctor, and the systems that are there. Ensuring that those systems are fast with low latency between the end of line or the terminal and ultimately the servers that may be aggregating or processing that data is important, because you don't want to have missed time because you're watching a wheel go around of waiting for those things to be processed. Beyond that, there's some new technologies out there, and you all probably have worked with them on real-time asset tracking. But what we're finding is the majority of these newer Wi-Fi access points already have the beaconing either through Bluetooth beacons or Wi-Fi beaconing to be able to track any specific piece of equipment. And in some ways, they're also tracking patients and clinicians to be able to understand where they're specifically at, and how much time are those clinicians interacting with the patient themselves. That being said, it's not a tracking from an HR perspective to see that you're doing a job, just to say we know that this amount of time has been allocated for care for these patients over a specific time frame. Okay, so I touched on cybersecurity before, but what does this really mean for things like hospital operations? Well, there isn't very much to say about cybersecurity other than it seems to be one of the highest priorities that specific personal information is trying to be captured, or ransomware, where they're taking specific data and not allowing you to be able to go after it. Imagine the scenario where somebody's electronic medical records were under a ransomware attack and you weren't able to provide them proper care, or there was a situation where there was a denial of service in a hospital. You can physically design a building to help with cybersecurity. Talk about those multiple entry points, being able to create redundancies, being able to put things into a secure cloud so that if there is a ransomware attack, you can get back up and running quickly, and it doesn't affect ultimately the critical care operations as you see them. What I would say is that cybersecurity is not just one department's requirements. There are those passwords that are required in order to be able to do specific things on networks and for electronic medical records. So you have to be worried about social engineering within these places, the ability for hackers to be able to be a man in the middle attack where they're taking in the data, they're able to scrub it and ultimately decipher what is good information for them to be able to exploit. What we all have to do is think about how quickly should we be thinking about this? And I would say we have to be thinking about it now, but in a new project or in a renovation project, how do we describe the specific attacks and how do we build an infrastructure around it, and failovers and redundancies and availabilities and backups, such that if those things should happen, there's a minimum amount of impact to the overall operations. So back from that specific point to then thinking about telemedicine and telehealth. Through COVID, we had accelerated acceptance of this because it became a much easier option and safer option for a lot of individuals. Patients like it. The majority, 90% of those who are polled asking about their experience with telemedicine or telehealth say that it was as good, if not better, than a experience in person. As we said, saves time. And then thinking about specialists in rural areas, those people don't normally get to be able to see specialists, and those who may be in a different location, they have a very narrow amount of clinicians that they can see, versus having to travel 2 hours or something like that to go find that specialist. You can quickly see how that can be advantageous to rural areas as well. Now, as with my own telemedicine appointment today, it's a very easy process, but there are some considerations that need to be taken into account when you're putting that together. Having proper lighting, either on the patient side or on the clinician side. Having proper acoustics so that you can hear if somebody is having problems breathing, if somebody's having problems with necessarily some sort of understanding or hearing. You need to be able to account for those things, because sometimes just having an iPhone doesn't replace a doctor. There are other things that need to be considered. Also, as part of that lighting experiment, you need to be able to render skin tone and as well any abrasions or things along those lines, or physical abnormalities, so that the clinician can be able to see those and either recommend an in-person or other treatment to further the patient's care. We're thinking about the data, we're thinking about the systems, but really what we're thinking about is the infrastructure more than anything. There's some tenets to how we design, and one of the most important things doesn't have to do with anything physically related. So what we talk about is that there's distance limitations to a lot of the Ethernet as well as cabling requirements throughout a building. So when you're designing, you have to have proper rooms. They need to be properly sized, not only for today, but the future, and any sort of migration from an existing network to a future network. All of those things need to be thought through. So sometimes you're going to walk into a room, you're going to see an empty rack, but if you were to do a paralleled system where you brought in the new equipment, they would reside in that new rack until it was commissioned and been able to take live traffic. So you need that kind of failover space, or that stretch the ability to install those systems. Then also beyond that, you need to be able to have the power and the cooling to those rooms to be able to do all that. Now that all needs to be started a little earlier than normal with regards to technology and the infrastructure design that is there. Those things unto themselves, they need to be able to bring a level of reliability and redundancy. And if we're just going with minimum compliant systems, it becomes difficult for that availability and reliability to work because it all has the nines of reliability, the 5 nines, the 4 nines of reliability, as good as its weakest component. So all of that needs to be considered when thinking about how to put in the design of those systems. The next is ensuring that there's proper pathways for the cabling to reside. Any adds, moves, and changes need to be considered. And through the trend, you know that as we went from Cat 6 to Cat 6A to Cat 8 in the United States, Cat 8 is more of a data center driven thing, but these cabling plants that are there, the only thing that's been constant is that it's been a larger diameter cable. So you need to properly size those for those adds, moves, and changes that will happen over the years. Yes, they are passive devices, but the reliability of those systems and the performance of those systems will dictate the performance of the end-of-line equipment and medical equipment that may be connected to it, inclusive of wireless. Doing proper wireless design with a survey that predicts what the propagation of those RF signals and how they can work better together to get the maximum coverage and redundancy, so that you're covering one area with more than one signal is important. Wireless and wearables have become a very big portion of the market, whether or not they have FDA approval or UL listing on some of those. They're still providing a level of safety and security, as well as data gathering for things like heart rate, echocardio, even through Apple Watches and those kind of things for rhythm. All can be considered as part of that future wave of technology. Other things to consider in design is ensuring that the fire stopping and smoke barriers have proper repenetrable pathways between one area of a hospital and then being served by another area of a hospital or medical office building, so that you don't have to have someone come out and recertify that fire stopping every single time that you need to be able to run a cable. That will save a lot of problems when you have the Joint Commission come in or others who are looking for situations to create problem statements for you and things to fix. That helps. And then finally, ensuring that you have the proper backbone as part of the design. Now, all of those proper systems together will create a very good system that can be reliable and redundant and available for those specific end of line or medical devices. But what really makes the most impact to a building is bringing in those technology or other system engineers earlier in the process. The earlier they're in the design process versus being kept to later time, the less impact they're going to have on the building's designs, because they are able to, through more flexibility, less than rigidity of the building's layout or the system layout, they're able to provide more coverage and the ability to be able to do a lot of those systems that not necessarily everyone is thinking about when they're thinking about the glazing or the civil grading and steel and early packages. You still need to be thinking about those two entries coming in. You still need to be thinking about, I need two main points of entry into my building. I need to be able to have redundant equipment rooms so that if one goes down, I still can operate. All of those scenarios are part of good building, hospital or medical office building design. And what I would say to you is that that out of all of those things, the most important is to start the conversation early. And that ultimately will dictate how you will be able to have a better system in place at the end when you're opening a facility or a new wing or a bed tower or the like. So MEP for medical projects, what I was talking about before with regards to how systems and technologies need to be considered, it's not just one system. It's not just the technology system needs to be reliable. All of them need to have a level of reliability and failover, as well as resiliency, to be able to, from the mechanical side, to be able to cool the rooms, from the electrical side, to be able to power and be able to have the availability of power when new systems may be migrated into technology or congregated onto an Ethernet-based or IP-based network. All of those things need to be considered early in the process, because they will help dictate whether or not there can be efficiencies of being able to provide only X amount of power versus Y amount of power. You can really get down to a better understanding of what equipment's going to be in the rooms, what systems are going to be there, and what needs to be cooled and or powered throughout. We talked about the proper lighting in buildings and proper acoustics. Now, patients will ultimately tell you that the proper acoustics within a space can make them feel better. And we all know that patient health and their perception quite often is a reality to the outcome of their stay. So having proper acoustics, so you don't have too many hard surfaces and the ability to design around those systems makes it a little easier for them ultimately to be able to have or receive better patient care. So a little bit of a recap. When you think about technologies, don't necessarily always think about the network components or the end-of-line devices or a monitor or a pump. What I'm asking you to think about in order to make the systems be able to flex to the changes within the medical field, the changing equipment, and the way that information is gathered and care is provided, is to think about the infrastructure. Because if you have that base platform of infrastructure, you can then bring in the technologies almost like an application, and you know that the infrastructure that you've put into place can be able to hold and be able to utilize all of those specific systems that will come in the future. We think about a hospital and it's got a 50-year life. What will the technology look like in 50 years? And you look at a building of any type, and in 30 years, how many times are you going to replace the electrical system? And quite often the answer is 0. But how many times are you going to be upgrading the technology and the systems that are there to be able to be upgraded and updated to the latest technologies that provide the best care ultimately, and provide the best tools for those clinicians and care providers to be able to do their jobs most effectively. And I would say conservatively, it's going to be a lot greater than zero. And maybe 3 to 4 times you'll see the upgrades of systems and the changeover of those in that 30 years. That being said, you also need to think about the room layouts for technology systems, network-based and IP-based. Think about the pathways that are required, ensuring that you have the availability to do the adds, moves, and changes, not just the minimum compliance. Beyond that, having the repenetrable fire stopping, so that you have the ability to go from one side of a smoke or fire barrier to the other, and then the backbone, whether or not it's fiber optic or other. Typically, it's fiber optic, so that you can be able to bring those systems in and tie into that backbone, so that their systems can propagate throughout the network and don't necessarily have to integrate within the network that's already there. If there's something that's more sensitive or HIPAA related or the like, you have that ability to be able to physically separate certain systems and equipment from what's normal. I really enjoyed talking with you today. I am keeping it short and sweet because I know that there's a lot of rabbit holes I could go down, and I wanted to give more of a highlighted view of technology and not trying to think about it from the standpoint of just the bells and whistles that sit at the end, but more of the infrastructure that can be flexible to allow any of those systems to be able to be integrated and not have to require a tremendous amount of change within it. So I want to thank you for your time. And then I think we're going to go to talk about if you had any questions or if you have any comments, just type them into the chat.
Okay. Yeah, please do enter. I don't see any at the moment, but let's hang on. There may be something forthcoming here.
And it's okay if you don't. It's not really this is not really the full process that you all are always thinking about, but truly it's an infrastructure-based discussion. What are the technologies that we're going to see coming up? I can't predict that. There are innovations that are there. Wearables are going to be a larger portion of it, but it all rides over an infrastructure for technology that needs to be mission critical, almost data center like in its availability and its resilience to events.